Yeah, thank you. Ooh, there it is. Thanks for having me. I'm not exactly sure uh, why my background qualifies me for wellness specifically. Uh, but they asked me to do this twice, and I said no twice. And then they asked me to do it a third time, and it didn't sound as much like a request. So happy to be our well-being champion. To start, as Tammy's pulling up the slides here, really, I think for me, part of why I was reluctant to take it on was I didn't really understand what we're talking about. I think well-being's a hard thing to wrap your head around and know how to sink your teeth into. So the way I'll frame this talk tonight is I think well-being is best, to me, understood as is a fight against burnout. That's why people care about it, because all of medicine and really a lot of different professions are struggling with how to deal with burnout and what that means. And well-being is the name that they've given to how we're trying to, do something proactively against it. So, as Dr. Lilhai mentioned, I'm a musician, I'm a songwriter. I process things in metaphors and illustrations as a framework for me. So, we'll start with a metaphor of a screaming baby. It's a happy metaphor for burnout as we try to frame this. So, Greg Ward can probably relate to this intimately. He's got a very young baby. So, if your parents, or we've all been around a screaming baby, but just take a minute, pause, think about what it's like to be around a screaming baby for 20 minutes that will not stop screaming. And just imagine, so you're sitting there, the baby's screaming, mom is trying to cuddle the baby, trying to give it a bottle, trying to rock it, trying to soothe it. There's no needle sticking out of it. Clearly it's breathing well. The diaper seems okay. Nothing's working. Dad finally loses his mind and walks in and screams, "Don't coddle the baby, just let him cry it out." And then mom's crying. And now everybody's very sad. And you imagine just the stress of that situation. So you're picturing that metaphor, and all the while on the back table, there's a bottle of barrier cream that would have been the solution to the raging, painful diaper rash that was the poor kid's problem to begin with. And my point of this metaphor for me is that the baby in this situation doesn't have the language to articulate what he needs or what's happening. He knows something's wrong. Mom and dad both hopefully know that they have the best interest of the kid at heart, but they're not on the same page. And they disagree on how to approach it. And they both came at this kid with assumptions about what that baby needed. And they were both wrong. And they didn't really investigate the cause of the distress. And so the idea to throw out there is part of burnout, I think, is it's relatively easy to diagnose when we look for it and when we start with a common best interest in mind. And it gets magnified by miscommunications and assumptions. My second happy metaphor for burnout is glioblastoma. Just as an uplifting idea for the neurosciences group. So burnout, we just said, is pretty easy to diagnose, but it's also really difficult to treat. We'll talk more about what the research is that backs it up. But in the neurosurgery field, certainly we know what it's like to face something on a daily basis that we've thrown a lot of money at, a lot of effort at, that we have not found a game-changing solution to how to treat. We diagnose it well. Big structures are throwing a lot of energy and smart people to fight it, but we haven't changed the game. And if it were simple, we would have figured it out already. If there was some simple solution to a glioblastoma, we wouldn't have missed it so far. So we have to ask, why is this defying our intervention? And I think in the case of burnout, it fits that description. And part of the reason is, we can go to the next one, is this idea that we keep falling into these traps of either comfort or grit as being a solution to burnout. And I think the truth is that neither one of them is an ultimate solution. So this is a couple of generations screaming at each other, which I think is how most well-being initiatives feel, at least to me, who right now feels caught between those generations. But it's easy for us to say, okay, well, it's millennials or Gen Z. They're lazy, they're soft, they're self-centered, or it's the boomers who are out of touch and workaholics and also self-centered. Or we blame Biden or Trump or Brene Brown or Jordan Peterson or Kim Kardashian or whoever. Both comfort and grit are important. I think they're a part of this, but they really don't explain what's going on. And I think part of the reason that they both fail is this is hard just because it's hard. It's not a simple solution, or we would have figured it out already. It takes people-on-people work, and it costs a lot of energy and philosophical flexibility and engagement over a long time to make a difference. And that makes it really hard to nutshell or find a great theme to. So the other piece of this kind of introduction, not quite there yet. Thank you, Tammy. One more back. There you go. We'll leave it there for a minute. The other challenge of this is we wonder if it's our job. So is it our job to deal with it? If it is our job, how much of it is our job? For a lot of us in medicine, we think of the workplace issues or the method of approaching work or our relationships as a distraction from our actual job. You know, our job is operating, period. The rest of it is BS, and it's a waste of our time. And I don't have 5 extra minutes to talk about how I engage with the team here or think about the well-being of the residents. Can they just be grateful that they're allowed to operate with me and soak up my genius and move on like I did? I needed nothing in residency. I took no vacations. I've never been weller in my life. So we have a problem of actually asking ourselves if we think it's our job to deal with it. So for your consideration, I would say if burnout, which we'll talk about, is emotional exhaustion, depersonalization, and reduced personal accomplishment, which is the definition of burnout, then part of the solution is developing an antithesis to that. That is not easy to do, but I think we can summarize, or I would summarize as kind attention, recognition, and partnership toward common and concrete goals. So to the question of is it our job, let's go to the next slide. I think the best summary of this is from Dr. Derby, who works at our campus now. This is her paper from when she was at Mayo in 2018. She's now the director of our well-being initiative for our whole campus. She put out a great paper with some colleagues about how to summarize well-being and burnout and what it means and what the status of that, the actual evidence for it is. So her definition is just what we talked about: emotional exhaustion, depersonalization, which they define as treating human beings like objects, becoming more callous in how we treat people, and I think being treated that way is also part of that too. And then reduced personal accomplishments, ineffectiveness, feeling like you're not experiencing value in your work-related activities. This is distinct from dissatisfaction. It's not the same as fatigue. It's not the same as depression. They measure it with this fancy survey that has great reliability and apparently is a real pain in the ass to implement in any real practice setting. So, like many soft science research studies, there's a lot of cool data, and it's really hard to apply to your workplace to get people to fill out super long surveys that are helpful. But when they measure it, physician data tends toward exhaustion and depersonalization being the most effective targets for physicians. The sad statistics are greater than 50% of physicians are experiencing burnout. It's way more than other professions. You can go to the next slide here. It worsens our patient care, increases our errors, increases malpractice suits, lowers patient satisfaction. The hospital has started this program because it's costing them a buttload of money. It's costing them millions of dollars, and it's lessening the effectiveness of physicians through absenteeism, turnover, quitting. They estimate that they're losing the equivalent of the graduating class of 7 medical schools every year in lost work from physicians because of turnover due to burnout. So the hospital really cares about it. That's why they've hired someone like Dr. Derby to help do something about it. It's also really bad for us health-wise. The super bad news for us graduating physicians is that our health kind of sucked to begin with. We have really high rates of depression and anxiety and substance problems, and burnout is just gasoline on all that. So burnout increases the risk of alcoholism. It doubles the risk of suicide, which is already way higher in certain physicians than it is in the general population. So they ask in this paper, what contributes to this? What are the problems? Inefficiencies, bureaucracy, Epic is a big one. So the addition of computer order entry increased burnout by 30%, that by itself. Workload, which certainly COVID worsened, work and home conflicts, spending less time while you're at work on your most meaningful activities, and the pay method. So pure incentive or performance-based models have higher burnout than salary-structured jobs, which is interesting. And then leader engagement was the last factor. So engagement from management, seeking input from your people, informing, recognizing individuals, improves burnout. The individual factors that we can't do much about, but are kind of interesting to note, are youth. So you're associated with burnout as a physician if you're younger, if you're female, if you have children. And this was the most interesting to me. If you have a non-physician healthcare professional spouse, you're more likely to be experiencing burnout, which I think none of those seem fair, but as we think about the causes for it and things it's associated with, I don't think they're surprises to any of us that have worked in medicine for very long. I don't exactly know why, but they're not huge surprises. So when you get to the strategy section, it feels reading this paper like we're just cops at the scene of the crime. This is a descriptive field at this point. Unfortunately, the strategy section is really thin. It basically says reducing work hours for residents seems to have helped, and that's it on the list of organizational interventions that have done anything consistent, which sucks. If you have my job now of trying to come up with how do we create this in our department, there is no blueprint, even from this really good research. There's some suggestions of mindfulness and, exercise and the things that when I was a resident, would make me furious at the idea of well-being, of when you're burnt out and someone tells you, like, well, can you just get yourself better, though? What if you just went for a swim and thought about your life a little more? So not a lot of strategies. What does that mean for us? Why are the strategies so few? I have a couple of ideas. This is not evidence-based, but these are my interpretations from reading this stuff and thinking about it. A lot of it's from the inside out. So some of this is workplace changes. Some of this is just life around us changing. Our culture right now is lousy with anxiety and depression and loneliness, and we have changing expectations from work. We don't agree as much about what's even true or what it means to be content in life or what the purpose for work is in general, and that makes it really hard for us to talk about how do we make work better. Number two, our structures are a lot bigger. Hospital systems are large. It increases anonymity and turnover and a feeling of not belonging to any place, and isolation and fragmentation, which we're all already coming in with from our individual lives. Number three is it's just really, really hard. It's a multidimensional problem. It varies by job type and what your department is, and we have the baggage of a lot of kind of half-assed corporate pats on the head, pizza parties or free coffee day for nurses that make things worse, honestly. I think they can worsen things, at least in our department I think they have. Number four, it takes buy-in to accomplish anything, and we're swimming in cynicism. So we don't believe in this as an idea, as a culture. I just think we don't. So you can't fix that. And I think we know as physicians that talk about a soft science angle. You know that when you're talking to a patient, if they believe what you're doing is going to help them, their outcome's going to be much, much better. Like, we know that's true. We don't know why, but it is true. And right now, when it comes to fighting burnout, I don't think we have a lot of buy-in from the people who are actually suffering from it right now. Number five, I think, is terminology. It's not the same as job satisfaction, but none of us are really that good at describing what it is or how to wrap our heads around what this term even is to talk about. So what do we do? I don't think we can do much about the first two things that are out of our hands. But the last three, I think we can fight to clarify what we're doing. We can try to learn how to establish buy-in. We can develop some perseverance and some willingness to dig in over a long period of time and enjoy even incremental gains in it. So the challenge to me is, how do you start with all this in a cynical, independent, almost libertarian-minded department with really low turnover, which is to our credit. We have a situation in our department where, honestly, if people really hated their jobs that much, they would leave, but they don't. So we're in an interesting situation where I think job satisfaction, and when this was borne out in our survey, job satisfaction is not that low, but it's about equal to burnout. And so that's where we're starting from, trying to understand what does that even mean. So we'll move to the strategy part, and this is what we've done so far. We can go to the next part. So how do we approach this? These are our first steps, our first hard steps of the soft science. Number one, draw boundaries and load the boat. So when I was approached with this, the idea of taking on an entire department that spans, Children's Hospital and Denver Health and the VA and a bunch of different layers of people was just way too much. So it's get people on board. So I decided to focus on just our campus, just University of Colorado Hospital, and focus on 4 discrete groups of people: our admins, our APPs, our residents, and the attendings. And then I loaded the boat because I didn't want to be alone in this. One of the first things you learn as an intern is don't be the only one that knows something bad is happening. And I did not want to be the only one that was getting these terrible survey results and finding out all this bad stuff was happening. So I tricked Jen into doing this with me, and along with a couple other friends, and loaded the boat. Next slide. So the next two things we did is we created a language, and we come up with a philosophy of identifying the intersection of the practical and the critical. So for us, that meant identifying some axes of well-being that included kind of a professional life, so your day-to-day work life, your personal life, so your personal safety, your personal health, and then our corporate life, so how we work together and how we do things as a group. We came up with a survey that we thought would elicit the maximum feedback and just would be a start of a discussion. And I've tried to, if anything, over-present over the last 6 months so that at least our department hears these terms a bunch and we start talking about this idea and it becomes part of our language. And then the practical and the critical. So what you don't want to do is waste your time spending money and energy on things that are easy to do but don't help anybody. That's the practical circle. Or the things you think are going to save the world but are futile. It's the edge of the critical circle. So how do we get some data that shows us where they intersect and where we can spend our time and effort efficiently? You can leave it there for now. And then all these things are building toward really how do we get buy-in? That's the whole point. How do we get buy-in? How do we define success? So buy-in meaning how do you slowly and get people around you to think this is worthwhile and think you have a chance at doing this? And how do you define success in a way that's not all or nothing? That's not fixing. We're not going to cure burnout. So we have to come up with a way that makes us feel not discouraged by starting this. And that comes down to, in my mind, setting things that really are more under our control. So our metrics of success as we start this year were make a team, make a language, get data, try something, finish the year with more buy-in than we had when we started, which is really easy because you start with about 0. It's hard to get worse than that. And make a system we can repeat next year. So if we do those things over this year, I think we can avoid discouragement. If you go into treating a GBM and your metric of success is 20-year survival, you are defeated before you start. If you go into parenting thinking you are going to never have a screaming baby that you can't deal with, or never make your wife cry because of that screaming baby, then you have already been defeated. And then our last thing was starting slowly. You can go to the next slide here. Theme of just starting slowly and don't quit. So when you get hasty with things, certainly in surgery, that's when mistakes happen. Going quickly encourages going alone. We're inheriting a problem that took decades to brew in medicine. And so the most important thing is that we don't quit. And hopefully these previous parts of our strategy decrease our risk of quitting. We can measure success. We're not alone. We're not in a hurry. We have an increasing amount of support because we're starting with nothing. So a little bit of support is even better than we had before. And we're trying to be reasonable in our approach. All that said, there is a sense when you talk about well-being, when I've done some of the stuff with the other people in our leaders on our campus, it feels, again, a little bit like, yeah, that's all great, but the baby's still screaming, or that GBM has come back. And there's a sense of just hopelessness, of the size of the problem, how much of the problem really is systemic, that feels like there's just, what are we doing here? You can go to the next slide here. In this section, just to break from this a little bit, it just reminded me of a story for me from when I was a sub-I and had my interview in your office, Kevin, Little High, where and I saw a thank you note on his shelf in his office, and the thank you note was from a glioblastoma patient. And it was so heartfelt and sincere. It was a thank you note from a family member. And I don't remember who it was a long time ago now, but I just remember leaving that office thinking, like, they are definitely dead. Like, that patient is definitely dead from that GBM, right? So what are they so thankful for? And if we stop and think about that for a minute, it just makes us wonder, like, if we're that frustrated by this, what are we really doing? And as I've thought about that intermittently over the years, I think what I would submit to you, I think it's because all of our care really is palliative care. And the truth is we really appreciate palliative care. That's what we all really want. And that just means care that's focused on the decrease of suffering. And that can be an increase in the quantity of your life. That can be an increase in the quality of your life. That can be 6 more good days than you had before. That can be 1 more week of being able to speak to your family. Like, all that is meaningful. And so if we set those boundaries and we go back to the themes of what causes burnout as a group, the idea that patient, why were they so thankful? Maybe because their problem was deemed worthy of attention that was articulated and explained, and that took away the fear and the chaos, and that attention fights the emotional exhaustion. Because that person received that their experience was valid and valuable and was worth the time of a really well-trained person, and that's recognition fighting depersonalization. And because they were on a team now with a directive on a playing field that had sidelines and goalposts, and they had a partnership and a common goal fighting a sense of reduced personal accomplishment. All of a sudden now they at least had, okay, we do surgery, we do radiation, we check this med, we check this lab, here's the blueprint. All that stuff, I think, leads to a theme, which is if we can treat each other in the workplace with the attention we give to our patients, then I think we have a chance at addressing this complex problem. And the last thing I would say is, next one, is just the idea of going back to the vocabulary. I would submit to you that I think thriving is a much more helpful weapon against burnout than well-being. I think well-being is a weak sauce term that none of us like to even say. Like, are you really going to ask someone if they're being well today? Like, how's your being? Is it well? Are you well? We don't talk like that, and that's not inspiring. And I think that's the problem of the difference. That's why you can have a job situation where you got a lot of satisfied people who are a bad 6 months away from quitting, who are simultaneously burning out. Because satisfaction is reactive. Satisfaction is, are you okay? Have we eliminated the things that make this hard for you? And that leads back to that cycle of comfort and grit and stuff that doesn't actually help. But what we really want, what we're designed to be, are human beings that are thriving. Thriving is proactive. Thriving is flourishing. If you pause for a second and you picture someone or something that comes to mind if you think of the adjective of thriving, whether it's in their work or if it's, in your garden or just a person you know, and you think about the adjectives that come to mind, they're much more stronger and livelier than the things that come to mind when you think about someone who's being well, at least to me. So I think of things that are engaged and alive and that are growing through challenges. I think I would submit that thriving is the enemy of burnout. And so what's our model? I think part of it is consider someone who's thriving in their work. and consider, is their emotional exhaustion balanced by kind attention and being filled up from another source? Are they valued and recognized as an individual? And then do they pass on that recognition and value to others? Can they tell that they're doing a good job? Do they have boundaries? Do they have feedback? Do they have markers over different terms? And a team to share them with. I think, when I think about that for me, and I can picture some specific people, I think those factors are all part of it, all part of what they, why they thrive in their job. So I think that's a helpful model to me of our corollary to burnout. And so finally, to the graduates, I know this isn't your official graduation, but I would say congratulations, you will burn out at some point. You will burn out. That's what the data shows, and it's real. We might as well just talk about it. You can't pretend the person doesn't have a GBM. So hopefully none of you have a GBM, but you will burn out at some point. And when that happens to you, my encouragement to you from the little bit that I know, having just started this process of learning about this, is don't settle for being well. Don't be satisfied with satisfaction. You were designed to thrive. You've worked hard for the opportunity to see how you'll flourish and grow into the depth of your field. And when burnout comes, it might be helpful to draw boundaries, load the boat, create a language, identify the practical and the critical, define success, start slowly, and don't quit. And my second congratulations is that once you get into your career, you will be the cause of someone else's burnout. So chew on that for a minute, that you will, I think we're all hearing this thinking like, yeah, I am burnout. That's right, the system is, and you will be the system someday. So before you eye roll the generation behind you, consider whether you actually know why they're crying, and whether what they need first is to be seen and to be unalone in what you may have forgotten is a really challenging situation. And consider that you also may not know what you're talking about, because our culture and our system are changing really, really quickly. But I think the themes that come out from the research of burnout, if we're going to trust what burnout is that the weapons against it will likely continue to be recognition and kind attention and partnership toward a common and concrete goal. And those will go much farther than any top-down initiatives that your system can come up with. And the last thing I'll leave you with, next slide, is if you want to skip all that, just start a band. It is the quickest way to fight burnout. It's free therapy, and you get cool gear and cheap beer. And it will be the quickest way for you to access some of these things. These are just some, they mentioned in the intro, I've gotten to live this other kind of side life over my career. That's my wife on the right. We met at a show. She's an artist as well, so we met playing music, and we've been in bands together. And the middle one is a band that I was in for a long time, and we were the ones that got lucked into getting invited to play at Red Rocks back in 2015. And then on the left is the current project I'm in now called Neurosurgery. And it's been super life-giving for me. And I think that's just my last reminder that all the hope we have for changing things here will pale in comparison to the work that we do from the inside out, to the way we get poured into on the outside of our lives and bring with us into work. And that's the end of my talk. Thanks for inviting me.